Good afternoon. I'll be talking on pre-op evaluation and surgical planning, little bit overlapping with Dr. Shah. I do not have any financial interest, but I always acknowledge these two people, Dr. Radhika and Dr. Raldave, always because I have learned a lot from them. And the journey, a little bit, I am talking, the journey of Boston Kepro in India started since 2008. And more surgeons are interested now in it. There are 10 centers, almost 14 to 15 surgeons are doing it, and Kepro supplied since 2008 to 30 in India. And also important factor is pricing factor. Though the price is increasing in US, but still in India we are getting 1/12 price of US. And our sincere thanks to Professor Dolman and his team in Boston. And you all know these things. These types are important because when you are planning for surgery, you need to know certain knowledge about the backplate and types of Kepro. Like you need some calculation on back of your mind. So this is the typical pre-op evaluation or workup Excel sheet we usually maintain. And mostly all of us we used to maintain this, and there are several columns in it. And if I go one by one, I have added in more considering our Indian scenario like address. This is important for follow-up. Other state, other country. Bangladesh is very close to our place. Then contacts, mobile number. This is very important. We try to track the patient in the post-op period because the actual treatment starts from post-op day. Accompanying person, family member, friends, and repeat counseling. Financial support of that particular patient for post-op medication and further add-on surgeries. And given written documents and several times counseling because these are essential. The patient comes with all these do the surgery, then you will see that there is nobody to follow up. Clubs are helped or from ministry fund that first money has come. But when you have asked for add-on surgery, they cannot come. So, and I have calculated my, why geographical location is important. If you see the major complication has happened, and most of them from Bangladesh, it is 50%. From Bangladesh and also one from Nepal. So end of an infection from Bangladesh, Lochmatas optic atrophy from Bangladesh. But if you consider my home state, because I can track them very easily, so this is one of the important criteria for selection of your patient. And Bangladesh, whenever I feel this photo I used to show, whenever there is a political chaos in Bangladesh, I have one complication coming after the chaos. So I am very scared about this Bangladesh population. Now I am not taking any Bangladesh. Otherwise they are good indication. Only contraindication is geographical location. So other things is already diagnostic part, already told, ECBA already discussed, ECBA and other eyes discussed, lead, conjunctival, all discussed earlier nicely. Then lens status is one of the important things to know that aphakic, phakic or pseudophakic. If it is pseudophakic, then you have to consider ACR or PCR. If it is ACR, then remove it, make it aphakic, then you need to know the axial. Then glaucoma surgery, VR surgery, either they are done earlier or not. And if you have VR surgery done, and it is a silicon field dye or not silicon field dye, because that actually gives, during surgery you will find some problem. Then IOP, we always rely on our fingers, so this is called finger tension, we no longer call digital tension. Sharma's score is very important. Then corneal diameter is important again to choose the back plate, because I repeatedly used to tell Tony that our cornea is smaller, we need 7 mm or 7.5, 8.5 millimeter back plate. Probably is bigger for our cornea. So you go on to conjunctiva, you have to do peritomy. If you are considering, you are combining with ameth glaucoma valve, then you are having a trouble, you cannot dissect the conjunctiva that much. So these questions, so corneal diameter is important, UHG scan and B scan, axial length, posterior segment pathology, and some comment about the optic health status. Then UBM, sometimes I do when nothing is visible inside the anterior chamber. So distorted anterior segment, pupil, iris, lens status, everything, it gives some clue. Then if you have PAM, potential acuity meter, or RAM, sometimes I use retinal acuity meter. And it gives clue about some of the visual potential. Then face photography, slit lamp photography, this is for documentation purpose. Then UBM, some of the cases, like this is the case with thermal burn. So if you do a UBM in different sector, you will be able to know that there is no peripheral angle open. So you need to do a glaucoma simultaneous sitting, and then there are other indications like previous glaucoma, many times glaucoma surgery. So that is very useful clue to give whether you will go alone or you will just do post-op Kepro, because the glaucoma complication which I have learned that almost 50% cases it happens over a period of time. And recently very good article has published. They have done the anterior segment OCT, and they have done over a period of time, and now they have tried to tell that probably we need to do all cases to take care of glaucoma, because continuous angle closure glaucoma is happening with a period of time. So this view of evaluation, the ocular summary is the medical and surgical, BCVA, then evaluate leads, blinks, tears. Then another thing is tension is very important, UBM and face photo. And there are some certain social thing is important, because it is otherwise surgery-wise it is very easy surgery. If you consider other kind of Kepro, this easy surgery, any PK surgeon can do it. So regular follow-up is the most simple. So address, case selection, nowadays my criteria is first one is the address, contacts, financial commitment towards further add-ons, because you need to, every time we ask something to be done. So repeated multi-level counseling, that is one of the multi-level means, one with the patients, one with the family member, one with the friends, sometimes the friends from clubs, local, they used to come. And always try to get some ophthalmologist or nearby eye care facility in the vicinity of the patient, and you try to get all the contact numbers. So they are the first people who probably will help you to get the better answer if something happens in the post-operative period. And surgical planning, you need to know that perivalvular anesthesia, exact Kepro, so inventory-wise, order-wise, I think Tony will be speaking about it. Then for phakic eyes, you need plano or plus minus 1 diopter IOL, that helps. So if you could make it pseudo-phakic, it is always helpful. So keep a standby 14 millimeter diameter PCL, sometimes is required for our patients' eyes, smaller eyes. Then donor stereocorneal button, again relatively healthier button, not necessarily very good optical one, but should always be a phakic one, because we need a larger diameter corneal button. Scleral patch graft should be ready for ameth glaucoma bulb. Keep standby stronger suture. I used to keep stronger suture like 90 or 80 sometimes. You need this kind of vitreous upthrust, and sometimes these are bad eyes, repeated cycles of flaring and mannitol, everything is required. Then you need to do anterior vitrectomy. Cartography said sometimes you go to the one or two cases I think. Keep a second assistant ready. Plan your surgery with glaucoma or think more is required. So keep them informed and mentally be prepared for a long day. The ideal cases I think already discussed, but I want to again stress the lower 3 points, that at shorter distance, initially this must be from locality within 100 kilometers maybe, good monetary support and commitment towards labor. This is my case where I had to do, because otherwise young patient. Somebody has advised evisceration, repeat therapeutic graft, corneal fistula. She came from evisceration, but I get a very good visual potential. So I thought I could try, and after repeated time, this patient is going fine for over last 4 and she is very close to us, almost 25 kilometers from my place. Shows 4.5 years, going to 6, 9, 10, 6, and she has not developed any kind of complications so far. So thank you very much for your patience here.